At this time, I'd like to turn it over to Dr. Scrace to go through his presentation. David?
Thank you, Jody, and good afternoon, everybody. It's great to have you all here. We've had some very productive conversations over the past 3 or 4 weeks about what's changing with COVID and what's staying the same, and lots of new things on the horizon. We will talk a little bit in our usual fashion. I'll give you a summary about where we're at with COVID and some of the newer variants that you've already asked us in advance about. And then I'm also going to give a little bit of an update on monkeypox, because I know there's a lot of interest among the New Mexico public and your readers, viewers, listeners about that as well. So we'll try to make sure we cover that today as well. I think Brianna, we'll just go right on to the first slide. And this is sort of a summary. You've seen this many, many times. And on the x-axis, the horizontal axis, you have the date. On the y-axis, the upright axis, it reflects the number of cases. And then this is actually day by day by day, those little blue bars that stick up. And then the darker blue or black dotted line is the average over the previous 7 days, which we use and have used since the beginning of the pandemic to make sure we don't overreact to just a change in one day or not. I think there's some good news here in a number of places on this graph. To the extreme right, even though it's in the gray area, you can see that the number of cases, PCR cases that are being reported is starting to fall off, and that's really good news. So we're happy about that. And the modeling team met this week, kind of confirmed that. They're seeing that in the future, the case counts coming down as well. Although you also may know, and we'll talk about this in a minute, we're cycling through an awful lot of Omicron variants over the past several months. And so they're coming and going rather quickly, making it harder to predict. I think the other thing I just want to mention is for the first 2 full years of the pandemic, the CDC had 10 cases per 100,000 as a high level of community transmission. And they relaxed that requirement to take it up to 28 cases per 100,000, what we're operating at now. That it's sort of a moot point this week because we're still above that line, but as you'll see in a minute, we're starting to see some softening in the case counts around the state, and so we're not all red anymore when we look at community levels. Next slide, please. One thing that's interesting and positive and really makes a difference to me, I think if you remember in January, we sort of signaled to reporters and the public that we were going to be paying a lot less attention to cases and a lot more attention to hospitalizations and deaths. And there were a lot of reasons for that. Death rates among different variants were different. We were seeing, we thought, a decline in the percent of people with some of the newer variants who were succumbing to their COVID infection. And we also learned through the first 2 years of the pandemic that our biggest challenge was really our hospital resources. Since the CDC came to that same conclusion as we did. And so now, and I'll show you in a minute what it looks like, but I wanted to focus on the fact that, you know, we've been through a number of peaks. This goes back, on the left graph goes back to September of 2021, and the big Delta wave, the double peak Delta wave we went through, and then a fairly, first peak Delta, second peak Omicron, and then a relatively quiet period for hospitals with very low hospitalization rates. And then with the summer months and the surge that we saw, you're seeing an increase, but my hospital colleagues tell me that they plateaued. Last month, their main problem was hospital workers getting sick, making it harder to provide service to a larger volume of patients. They're also telling us that's coming down. But there's another thing here that's pretty cool and that worth noting, and that is you can see that on the 13th, which is yesterday, we had 176 cases and only 10 people on ventilators. That's less than 6%. And that, and you know, if you don't know this by heart, we started the pandemic with as high as 20% of people being on ventilators, and it's slowly come down. It was 10% during the initial phase of Omicron, what we now call BA1, and now it's down even more below that. So what does that mean? In addition to not seeing the same number of deaths, it seems like we're seeing less serious disease. Now, that doesn't mean that the virus is getting milder, and we'll talk about that in a minute. Two, what it means is the combination of, what it means is the combination of the characteristics of the virus, the number of people vaccinated, and people actually taking treatment has really, really improved. And so I got a little text message that our event rate yesterday might have been 22. There might be an error in the slide, so thanks for that correction. But nonetheless, clearly the trending in the past couple of months has been below 10% of people on ventilators, and we don't really react to that single data point. But I've been watching this really closely every day, and it appears that the combination of the evolution of the virus and the preventive and reactive measures we're taking to the virus when we all get sick is working, and much, much less serious disease now than we've seen in the past. Next slide.
Dr. Grace, the 10 on ventilators was for July 7th.
Oh, okay. I was going by the title of the graph. I'm sorry. And then I alluded to this, but here are the community levels in the United States by county. On the left, you can see the whole country, and you can see that what was a red map just a month ago is now gradually softening. Sorry, an orange map. I'm not good with colors. An orange map a month ago is now softening. We're seeing a lot of yellow and green, and even in New Mexico, we're seeing a lot of yellow and green. And actually, you know, we took a little bit of a detour or deep dive into the Northwest, which is still orange. And why is that happening? Community levels are based on three things: the number of cases, the number of people in the hospital with COVID, and the percent of people who are in the hospital who have COVID. And that orangish red Northwest that includes Bernalillo and Socorro and Valencia counties is actually mainly driven by the number of cases, not hospital capacity, which seems to be holding up pretty well over the past couple of weeks. And so I'd encourage all of you to familiarize yourself with this website, and we go by the CDC direction now, follow the CDC guidance, and because on that same page, and it's here, on the same page, you can find what should I do if my community is green or yellow or orange. Next slide. Some great questions from reporters. Thank you in advance about BA2. I'm going to kind of start with the graphics and move my way to the left. On the right-hand graph, this is the national prevalence of different variants as measured by a lot of different labs, and especially important to include our own state lab division here in New Mexico, the SLD lab, of the distribution of variants. And I think you're also familiar that things come to New Mexico a little later, 2 to 4 weeks later, than they come to the East Coast and the West Coast, which is good because that's 2 to 4 more weeks opportunity for us to get really good data about what's actually happening. But you can see nationally that BA5 is by far the predominant variant, followed by BA2.12.1 and then BA4. For epidemiologic purposes, we kind of talk about BA4 and BA5 because they're pretty similar variants. But if you go back to the left side of that graph, you can see we started off not that long ago in early April. BA1 was fading out. That was the January, a giant spike, and BA2 had taken over. Now BA2 is fading out. We had a period of BA2.12.1, and now we're mainly into BA4 and BA5. I read something in the paper 2 days ago that now the latest variant is BA2.75, and I was wondering if we were moving to grade point averages to describe the variants, but that was just a little joke for my academic colleagues. And then in the next graphic to the left of that, we have our table that we always show you about when a new variant comes out, talks about what we know and what we don't know. And so, both of these, the BA1 that we started with and the BA.5, we showed you the BA 1.1, this table in January. Now we're showing you BA5. And it always starts out with us not really being sure of some things. Interestingly, some people are predicting from out of Australia that the spread rate might be 18 times higher than the original strains we saw, which works out to 2 to 3 times higher. Actually, I suppose you'd say 2 to 5 times higher than the spread rate of Omicron in early January. And so, and I think you remember at the time, 8.2, we said, wow, that's almost as high as chickenpox, which is about 9. And so it's possible, and I'm not sure I believe these numbers yet. They're purely estimates. They're not based on a lot of data, but I do believe that in actuality, we're looking at a fairly much higher spread rate that could even be higher than measles, which our effective, or that spread rate, is 15. Measles is very infectious. And so, but I think this is a common sense sort of piece of information, because at least most people I talk to these days, back in January, they said they knew more people with COVID in January than they'd known the whole previous pandemic. They were saying the same thing in June and early July, and that's due to the ease at which the virus spreads. So bad news and good news, but exactly what we'd expect. The virus actually wants to live with us. So it evolves over time to more easily infect people, but it reduces the number of people who are killed. And that's what we normally see in any kind of viral spread or pandemic, is that slight decrease in severity of illness, but an increase in infectiousness. And so you can see that we know that BA.5 already is resistant to some treatments. We don't know for sure if it's resistant to the vaccine, but we do believe that we're seeing a lot more breakthrough cases now than we were in the beginning, which makes perfect sense. We have a 2-year-old vaccine, and that was based on the very first strains of the virus, and now we have dozens of evolutions of the virus. So we're seeing more breakthrough cases and counts, but less hospitalizations and deaths, which are the two primary things we're really looking closely at. So we're only up to 33% in New Mexico. Mike Edwards, our lab chief and director, tells us we're certain to follow the national curve. And so BA.5 will be the most common variant early in August, following that sort of 4-week delay that we see from both the East and West Coast for things coming to New Mexico. So next slide, please. So news on vaccines. I think you all know this already, but there is a vaccine available for kids between 6 months and 4 years old. We've already administered 2,464 doses. I did want to give a shout out to some of our highest vaccine administrators, to the ones who've given the most vaccines for our kids in this young age group. Albertsons, one of our Albertsons that had 372. So that's more than 10% of all the vaccines. Our public health division, stalwart public health heroes, ready to adapt to any new permutation or mutation in the virus, next at 254. And the Corrales Fire Department, who knew, launched a big vaccine campaign to vaccinate kids. So, kudos to the Corrales Fire Department. If you know someone who works for them, they're probably too busy putting out fires to watch this press conference, but let them know. We gave them a shout out today. And you can see the one thing that I find most interesting about this is that, the older people in New Mexico, 65 and older, the people I talk about, my people, because I'm a geriatrician, they've done really well on vaccines. I think more of them can benefit from the booster than have gotten it. There still is good protection for the booster. And also remember that other people are more susceptible as well. So maybe it's a grandparent, but it could be someone in your family that's immunosuppressed, or someone who's undergoing chemotherapy, and we need to be really careful not to infect them. We still have many New Mexicans who are at higher risk for serious COVID, and we do want to take care for them. And we need to all work together and do our part to keep everyone safe. So you can go on to our websites, the government website and our New Mexico vaccine website to schedule an appointment for your child or for yourself, for a booster, whatever. And we want to keep immunizations up. And speaking of that, I don't think I have a slide on this, but just to preempt the question that's coming up today, and I don't have my little cheat sheet here, but there was a new vaccine announced this morning. But just so everyone knows, we've been talking about the need for new vaccines and how great it would be if we had a vaccine that was more specific to both, all of the Omicron variants or the Omicron viral structure. This is not one of them. It's sort of an additional vaccine. It was first released, I think, November, December in Europe, and it is now being used and available in the United States. The one thing, though, is if you're a person who's decided not to get the vaccine because of the way the vaccine is manufactured, or concern about fetal cells in the vaccine, even though most of these vaccines don't contain them, this new vaccine does not contain any of those products for sure. And so if that's been your last thing that was keeping you from getting vaccinated, now there isn't a good reason for you. Now, other people still have valid reasons, and we're not saying anything about them, but if that was the only reason you weren't getting vaccinated, now you have an option, now you have a choice, and please go ahead and go online and learn more about how you can get that vaccine. Of course, the thing is, it's approved by the FDA, not by the CDC, not by their committee that reviews the vaccines. So it's probably going to be another week or two before it comes on the market. But keep your eyes peeled for news from your local media folks about when that vaccine really is available. And of course, we'll have a press release when DOH is able to provide that as well. Next slide. And so, as I mentioned, we really are looking at, for the most part, to do everything we can, to protect all of us. And, please be aware of the community level where you live. We have signs in our office about both community level and community transmission level. We follow both because we've got healthcare workers who work in our office here at the Human Services Department, where I happen to be sitting today. Get up to date on your vaccines, consider those boosters. If you are having symptoms, get tested immediately. And we had a big pitch for a really long time, and you all did really, really well ordering those vaccines online. Ordering those test materials online. Our stack is dwindling, but I know at the DOH website, there's ways to replenish your supply every month. The federal government has a different schedule, but they've already sent out 3 sets of vaccines to those who apply. And if you never got any, you can sign up actually for all 3 of them. So that's a good thing. Have those tests at home. If your home test is negative, but you're still sick or getting sicker, you can test the next day. But if your symptoms persist, that's a good time to seek out PCR testing. And again, you can find that on our website where to schedule that. Treatment, really big deal. Reduces the chance of being in the hospital by 89% for one agent, another agent a little bit less, but one test positive, one symptom, one risk factor equals treatment. And we're doing well. We're cruising from 2,000 to about 2,500 treatments a week. We can do even better with that, but remember that one test, one symptom, one risk factor. And remember, risk factors could be things like high blood pressure that a very high percent of people over 65 and 75 have, although younger people have it too. And just being over 64 is a risk factor as well in that equation. And then remember the masks. I was on an airplane recently. I got a background thing going to keep the backlighting down. But I was on an airplane recently, still wearing an N95 on airplanes. Probably I always will. I wear that or my KN95 in the office when I'm with other people. And another thing we can do to protect ourselves, but also people around us, and much, much, much more effective masks than the ones we were using 2 years ago. I like to say that I had some conversations with reporters this week. This is a completely and totally different pandemic that we were in 2 years ago. And while the case counts might be just as high as they were at some of our peak periods, our hospitalization rates are incredibly low comparatively. Our death rates have dropped substantially. We have vaccines, we've got treatments, we've got better masks. And so we're much better equipped to really fight this virus now than we've ever been before. Next slide. And then I'm gonna, I'll speed up a little bit because we want to allow time for questions. A little bit on monkeypox, and thanks to Laura Parahone, who's our acting state epidemiologist. Thanks, Laura, for sending this information. And she updates me on a really regular basis on this. Almost every state has a confirmed case of monkeypox. You can see here a few that haven't. We test for this in our own lab. We test for the family of viruses, orthopox, cowpox, and smallpox, but smallpox has been eradicated. And so if we get a positive test of that history, we know the person has monkeypox. It's very rare. We're never going to have to need, I don't think, and there's a very low probability we'd have to mount an effort like we have with COVID. It was first discovered in 1958 with 2 initial outbreaks. And, but more recently, it has been reported in several people in several different countries before we saw this outbreak. I think today New Mexico has 4 cases that we have confirmed in our state. We do send them on to the CDC for confirmation. But because of the overall low number of cases, we are just going to rely, as we're doing today, on the CDC map to report this out. It's a pretty quick turnaround time once we notify them, and so you'll see this updated most days of the week now by the CDC. Next slide. A few little tips. Usually monkeypox starts with a flu-like illness like influenza, with sore muscles, maybe a cough, runny nose, plugged up head, and fever in some people, not in others. But the key factor really is the progression to this characteristic rash. Often occurs on the hands, which is very characteristic, but can occur on other parts of the body. And so, if you have had a flu-like illness and then you start getting a rash and you're concerned, or you've been in contact with people with monkeypox, really worth getting a hold of your provider, getting it checked out. Not every skin rash on a body needs an immediate evaluation, but if you fit into that flu and then rash, think about getting that checked out. Another thing that's way different than coronavirus, it's a very different virus, is it can take up to 21 days from exposure to when you start having your symptoms. And so a much longer time frame means it's harder to trace people back and find out, where they got it or how they got that. And then one last slide on monkeypox, just for everybody. Well, what can I do to make sure I don't get monkeypox? Number one is very, very, very small number of people are going to get it. It can be spread as soon from the time your symptoms start. So if you're around somebody with a flu, then great time to pull out your mask if you haven't been wearing it and wear it. Avoid close skin to skin contact, which we should be doing with people with influenza as well. And particularly if people have a rash. This is always, transmitted from kissing, hugging, cuddling, having sex. There's been some confusion because there's talk about the fact that it could be spread through respiratory secretions, which means saliva, what we nonchalantly in medicine call pooling of secretions, but it's not flying through the air or circulating in the air in the same way we know coronavirus, influenza, and other viruses do. So also though, things that we do when we have a cold, don't use the same eating utensils, cups, plates, toothbrush as someone with monkeypox. That seems pretty obvious. And then also be aware though, that if you're handling bedding, sheets, even putting them in the washing machine, you could potentially contract it if there's secretions there that adhere to the skin. So be aware of that. But again, that's another thing that washing, frequent hand washing can involve. Because of the long recovery time from the start of the flu to the crossing over the viruses, people will be quarantined with this much, much longer. Could be 3 or even 4 weeks on the outside end with this. And so it's a different approach to a very different disease, but it's in the news. We wanted to give you our update. Use the CDC site to see what's happening with cases in New Mexico. And I think with that, I think that was my last real, oh no, there isn't. I have one more real slide, and that is on monkeypox. We're not going to be presenting on monkeypox every month on this, but we wanted you to have this intro. There is a vaccine. New Mexico had 0 supply of vaccine before we had cases. Now that we have cases, we're being shipped 362 doses of the vaccine. It's a 2 vaccine series, so that'll cover 181 patients who are basically the contacts of the people who've acquired monkeypox. We will be getting a lot more in the coming weeks and particularly next month. And then we are going to, also there is treatment for this that's approved, viral treatment for smallpox and monkeypox, and that we're going to be we're arranging with the CDC to get those medications for the people who are infected. Some of our cases, of our 4 cases, have chosen treatment. 1 is deferred, and 1 is thinking about it. Next slide. And that's it. So Jody, I'm going to turn it back to you, and we'll go to the Q&A portion of our time.
All right, let me see if I can do a little technical issue so that I can get a gallery screenshot. We have a couple of people who have raised their hand. Gino Gutierrez is first. Gino, I'll unmute you shortly. Would you please remind us of your media outlet? After Gino, we have Julia Goldberg from the Santa Fe Reporter. Gino, you should be unmuted, and if you'd like to turn your camera on, please do so to ask your question.
All righty. Thank you, Dr. Scrace. I appreciate your time. My question is just regarding the transmissions levels we've seen in New Mexico. You mentioned there's been a lot of breakthrough cases with the BA.5 variant, and a lot of the state remains in either a medium or high transmission rate. Just curious, you mentioned a lot wanting to have people encouraged to be wearing their masks indoors. Dr. Fauci even said that he came back from having COVID for 2 weeks. Just curious what the Department of Health is considering next steps with this variant, since there are a lot of reinfections going on with it across the country. Is a mask mandate on the table, and what other steps are you guys considering to kind of negate this wave of infection?
We're not having any discussions about mask mandates anymore. That was for the pandemic we had 2 years ago, not for the one we're having now. And I think what we're considering is continuing to encourage all New Mexicans to do their part to prevent the spread of the virus. The simplest and easiest one is staying home if you're sick. Don't bring that virus, whichever one it is, to work. The second one really is, of course, vaccine. The third one is treatment if you get sick. Fourth one, mask. But if you're strictly talking about spread, then what we're really talking about is don't come to work sick, don't go out if you're sick and interact with other people, be vaccinated and wear your own mask. And so, but I think we're relying on New Mexicans to use their own good judgment to protect themselves and their families, and not any specific direction at this point in time from the Department of Health.
All right, thank you, Gino. Gino is, I believe, from KSFR Radio. And now we'll go to Julia Goldberg from the Santa Fe Reporter. After Julia, we'll have Jared from KUNM.
Thank you, Jody. I have two quick questions. Hi, Dr. Grace. Thanks for taking our questions.
Yeah, sure.
My camera's not enabled, so
Good to see you again.
I'm grateful for that. The CDC earlier this week released a report about the rise in drug-resistant infections during the pandemic for hospitals, a particular spike in nursing homes, things like salmonella and staph infections, TB, and a bunch of other things I am not familiar with and sound terrible, and a rise in maybe misprescribing of antibiotics. And one thing that stuck with me was also a decline in the data for that because so many resources were being used for COVID data. I'm just wondering if that's on the health department's radar and something that you've either heard about or are taking a look at. And my second question, I'll just ask them both now, is I'm just wondering if you think there'll be an impact here from the recent FDA decision to allow pharmacies to prescribe Paxlovid, and if that's kind of in the mix.
Yeah, Julia, I have not gotten yet to that CDC report. I think that one thing that does happen that we've noticed with telemedicine is because you don't have the patient right there in front of you, it might be easier to prescribe an antibody because of that slight increase in uncertainty, particularly if it's over the phone. But I'll read that study and work with Jody to get back to you on our thoughts on that. I apologize, I'm not fully prepped for that one today. And then on the pharmacy ability to provide Paxlovid, this is something we're really excited about. Our pharmacist, oh my gosh, I have two Courtneys and I'm remembering the wrong last name. Courtney Lovato is our DOH pharmacist. Absolutely outstanding, already working with pharmacists to get them up to speed. There are some very strict requirements for pharmacists to prescribe. They have to have a complete access to the patient's medication list. They have to have complete access to the patient's laboratory results, which is what doctors have when they treat patients. We have a strong recommendation that all prescriptions for Paxlovid be in the electronic medical record because there can be drug-drug interactions, but it's something we're excited about, something we're anxious to promote, something that Courtney Lovato is already working really hard on to get the word out and work with pharmacists. And we're also working on interfaces to databases that are available within the state and to get folks access to. Now, pharmacists should have a pretty good idea if the patient gets all their prescriptions at their pharmacy, what drugs they're on. Not always though, because sometimes people stop it and they tell their doctor, but not their pharmacist. But I think getting at the laboratory results is going to be our biggest challenge. But as I mentioned, Courtney and others hard at work to get that to happen. And so our pharmacy team has really been, and there are a number of them. I work mainly with Courtney and Leo, but they've really been superstars in New Mexico, getting the word out about Paxlovid and other treatments, driving up our number of treatments from what was early on, like 50 to now 23, 2,400. And so we really think that treatment is our main way of preventing too many hospitalizations as this virus continues to mutate and continues to bob and weave, and we continue to chase it. But we think that the treatment is a critical factor to prevent hospitalizations. Given that people still are going to interact, going to spend time together, the virus is going to spread. That's just a given, and we accept that.
Thank you.
All righty, thank you, Julia. Next, we're going to go to Jared from KUNM. Jared, you should be able to unmute and ask your question.
Thank you, Jody.
Oh, something happened. We lost Jared.
He's back. Jared,
Can
you're
you-
on mute. There you go.
Can you hear me?
Yes, we can hear you now.
Okay.
Thank you,
Yep.
Jared.
Not sure what happened there, but thank you so much, Jody, Dr. Grace, for the time. I'm going to try to just see if I can sort some cognitive dissonance. So we just crossed 8,000 dead from COVID-19 with yesterday's report. The DOH's own internal assessment is that up to a third of New Mexicans are at risk of serious illness to COVID-19. You answered the first question by indicating NMDOH has no intention with the BA.5 variant to do new messaging, different outreaches, different strategies. So it all begs the question to me, what is an acceptable level of transmission, people out of work sick, hospitalization, or mortality? What is the goal on COVID prevention for NMDOH now?
Yeah, it's a great question. I think the cognitive dissonance people experience mainly comes from comparing 2020 to 2022. And that's why I was talking about the fact that I really believe we have it's a completely different pandemic than it was then. So I don't experience the same cognitive dissonance because I think we've declared and are acting every day, focusing on hospitalizations and deaths. The death rate, as I mentioned, is slowly declining with new variants. We're not seeing the same percentage of people dying from COVID, partly due to changes in the virus, we assume, partly due to things like vaccines and better masking and treatments and the like. I think an acceptable level of people in the hospital is really no more than our hospital system can handle. But I think if you ask the hospital folks that, they would say a little bit less than that. They need some breathing room. And so I think but we are really closely monitoring hospitalizations and deaths. And yeah, and thanks for bringing up our 8,006 deaths as of yesterday, because every one of those people, every one of those New Mexicans, has a family, has coworkers, has friends. There's an empty seat at the dinner table for those folks. And that does go all the way back to 2020. That part hasn't changed, but we are actually quite reassured about the fact that the percent of people who passed away from COVID at various stages from, original to Alpha to Delta to early Omicron to current Omicron, it's a stair step going down in terms of mortality rates, and that's reassuring as well. But it does really beg the question. I think in the end, we all have to do our part. We all have to protect ourselves and our vulnerable family members from the disease and continue to do those things we know that work. So I think no death is acceptable, and I would prefer that the target be 0, but there also is a dynamic in society between freedom and, and public health. And I think that New Mexico may have done a better job in managing the certain restrictions early in the pandemic, but we don't feel at the present time that there's a need to reinforce those. Jody.
All right, thank you, Jared. Next, we're going to go to Garrison Wells. I don't know if he is able to raise his hand. He put his question in the chat, so I'll go ahead and read it out loud for him. He's asking, it seems that like BA.5 is taking off in other parts of the country. Is New Mexico underplaying the potential impact to residents, or should the state take some steps before it hits hard here?
Yeah, I think the state should take steps. It just depends on the definition of state. So I think everyone in the state of New Mexico should take steps to revisit their own strategy, to think about the gatherings they go to, and with this very high case rate. And remember, the case rates we're reporting seem low, but that's only because they're a fraction of the total number of positive tests that we don't have because so many people are testing at home. We like that people are testing at home. But yeah, I think everyone in New Mexico should be taking steps, but we're not seeing other states imposing restrictions again. We're not seeing other countries who are about at the same place in the pandemic as we are imposing much in the way of restrictions. And I think most other states, most other secretaries of health of other states, ministers of health and other titles in other countries are feeling like the tools we have right now to fight the pandemic are so good that overarching government requirements aren't needed. So I think, yes, everyone in New Mexico should be careful, and that's our best way to fight the B5 wave, which I think we believe now is, even though the percent of virus isolates that we get and sequencing that we do will eventually get to 100% or close to it with BA5, the total case count is actually going down now. And hopefully data over the next couple of weeks will confirm that for us.
All right, thank you. Next, we're going to go to Brianna Wilson with KOB4. And after Brianna, we'll go to Natalie Juarez, whose media outlet I'm unaware of. Brianna, you're unmuted and you should be able to ask your question. I think you need to unmute yourself, Brianna.
Thank you. Sorry, can you hear me now?
We can hear you. Thank you.
Okay, I apologize. Thank you, Dr. Scrace. I just wanted to address a recent poll. Los Alamos was rated one of the healthiest counties in the U.S. Now it has the second highest infection rate in the nation. So I'm just kind of wondering, is the state keeping a closer eye on Los Alamos, or what are the communities that have the highest infection rates in our state that the state is keeping a close eye on?
Yeah, no, great question, and appreciate the opportunity to talk about it. One of the things that we know about this data is the less number of people you have, the more variation there could be that isn't real. And so while we're seeing an uptick in cases in Los Alamos, certainly they have just a very tiny fraction of the number of people in that county than we have, for example, in Bernalillo County, where we know in any given week that those numbers are accurate. I'm hoping that people in the Los Alamos community are looking at that map that I showed earlier, seeing that Los Alamos County is red, scrolling up to the top of that CDC website that talks about indoor masking and talks about social distancing and keeping those practices up. And so I think that community has the resources they need to fight this. It's, all communities in New Mexico could do better when it comes to booster shots and getting those booster shots. They could still get extra protection from hospitalizations and deaths. But right at the present time, the hospital system in Los Alamos and Santa Fe isn't overwhelmed. And so while we're seeing more cases, the main things we look at, which are hospitalizations and deaths, haven't spiked.
And I was noticing on the state's dashboard that all of the counties are in red right now, which is a little different than the graphic that we saw at the beginning of the presentation. So is that just because it's not updated, or?
Yeah, no, good question, and it's confusing, and I get confused, and I would show you this on the CDC website, except it takes a long time to update. And people who still have their hands raised would probably get annoyed. But there are basically two maps that are there on that website. And there's a link to update the website to do one or the other. The map I showed you is community levels. And that is the map I showed you. And that is accurate and up to date, I believe, from today, or at least last night, from the CDC. And that's the measure that takes into consideration the case rate and the number of hospital beds filled with COVID patients and the percent of hospital beds filled with COVID patients. But if it's any one of them is red, then you're red, or orange, sorry. And in this case, it's the case counts that are making it orange. And then there's another one called community transmission levels. And that's for hospitals to use to make decisions about things like visitors and quarantining and how long their employees have to stay out and come back and things like that. And so that one isn't all red either, but it's almost all red. It's, I think, maybe or orange or whatever it is. I think Ketron County might be yellow, and there's a little teeny county on the east coast of New Mexico that's blue, but the rest of the state is red. And so there are two different maps, but if you, that's how you resolve that discordance. And like I said, I'd love to show you, but I did it this morning and it took me about 5 minutes to get the maps to fully update. So go on there and play around. If you have trouble, let Jody know and we can walk you through the steps offline here.
No, it's no problem. Thank you. And I only have one more question because I do want to be respectful of the other reporters waiting. I'm just wondering how far we are from treating COVID infections like any other illness, you know, like the cold and the flu, without regular reporting and isolation requirements.
You know, that's a really good question. And we talk about it all the time. And I think what you're seeing the state do is gradually move to, you know, we're giving you those 6 numbers every day. But we used to give you like, I think it was 210 numbers every day, you know, with all the county level detail and everything every single day. And so we're gradually evolving to treat this more like a normal viral infection. There's 2 reasons we can't, and well, probably more than that, but one reason is that, you know, it hasn't really become seasonal yet. I mean, everyone's saying it's tending toward being seasonal, but we had a big, you know, we keep getting these big runs of infections in the summer, and normally respiratory viruses occur in the winter. So that hasn't quite panned out yet. And then the hospitalization rate and death rate, although dramatically dropping, still are well above influenza, at least right now. And so I think those are the 2 things I would look at. If it got to the influenza level of hospitalization or death rates, I think we'd probably be ready as a state to move it into that category. And of course, the CDC kind of coordinates a lot of efforts, and so we'd probably follow their lead as well. We work really closely with them, and I think they're providing really good data to New Mexicans and people all over the United States. So I'm kind of counting on that as well.
All right, thank you, Brianna.
Julia
We're
says,
going to end promptly at 2, so let's try to get through the rest of these questions. If there is time, we'll go to round 2. Next, we're going to go to Natalie, and she is with KRQE 13. Natalie, you should be able to unmute yourself and ask your question.
Hi there, can you hear me all right?
Yes.
Yes. Hi, Dr. Scrace. Thanks for taking the time today. So according to the CDC's website, they estimate that only 1 in 4 COVID infections were reported throughout this pandemic. I was curious, how many unconfirmed cases do you estimate there are in New Mexico for every confirmed case that we're seeing?
You know, I have a range because it's like we don't have the data to really know. You know, I always ask everybody who tells me they're COVID positive, and there's been a bunch of people lately, like, what kind of test did you get? And, you know, I would say that about 1 out of 6 people say a home test. But I think the data that we have out there that isn't as good as I would like pegs that range between, for every 1 PCR test, there's 3 to 8 additional tests out there. And so we're just not sure, but I think that's a reasonable range, and 4 is in there. The CDC number of 4 is in there, and so they may have some better data than we do. So I think that's a fair one. Sometimes I just multiply by 10 and divide by 2 because that's faster for me, which would be 5. You know, 4. I multiply by 10 and divide by 2, which is 4 cases for every 1 PCR, and when you multiply by 5. So. But I think that's a real part of what we're seeing now, and also kind of reassuring, because even with the PCR tests, our hospitalization rates are low, our death rates are lower. If you add in that estimate, they become much, much lower, and that's good news.
Thank you so much.
Thank you, Natalie. Next, we have Ryan Botel with the Albuquerque Journal, and after Ryan, we're going to go to Jamie Prito. Ryan, you should be able to unmute yourself and ask your question.
Hi, thanks, Dr. Scrace, for taking the time to talk with us. One kind of a technical question, is there a public health order that expires tomorrow related to like masks in healthcare facilities and nursing homes. And I think there might be some other things like businesses have to report if they get an X certain amount of cases. But do you plan on extending that, or could there be this order ending tomorrow?
Yeah, no, that public health order ends pretty much every month on the 15th. And so this year I planned my vacations around the public health order on the 15th in both July and June. And at the present time, we don't plan to make any changes. I think we want to see if we can get through the summer and get more people immunized, but there aren't any big changes under serious consideration. Our hospital facilities, nursing home facilities appreciate the fact that we still have that order in place. It helps them with their employees to say this is just a requirement. Actually, in the case of hospitals, the Center for Medicaid and Medicare Services, CMS, also has that requirement in place. So ours is somewhat duplicative, but at the present time, we don't have anything in line. We're beginning discussions about rapid responses, which kind of connects, Ryan, to your point about businesses, but that's one of those things where the meeting is being scheduled and we'll talk more about it and probably reevaluate the scale in which we do that. But I think the public health order is being written up now to be just a 1 month update to the one last month.
And then real quickly, if you don't mind explaining in some detail, earlier on one of your slides, when you had the Omicron BA.5 and another variant, you had said that they were both resistant to treatment in some effect. It just said yes. And you also said that you were hoping, Paxlovid is a good, tool moving forward. Is Paxlovid and some of the other treatments, are they successful against this new variant?
Yeah, I thank you so much for asking that question, because I should have thought of that as I was talking, but the main treatment resistance we see are with the monoclonal antibodies. And it makes perfect sense because the monoclonal antibodies were designed to attach to a certain part of a certain variant and take it out of commission. And it makes sense that the virus itself, just through evolution, would move to another configuration that would evade that medicine that was specifically designed to knock off its parent, right? So that part makes sense. On the other hand, Paxlovid is an antiviral drug that we have no reason to believe the virus will evade. And the analogy I give is, cold sores, herpes simplex 1 virus, we've been using acyclovir and some other relatives of acyclovir. Gosh, I've been using them for most of my career and they still work. And so they operate on a whole different mechanism around viral replication and the like. And so I'm really counting on the fact that Paxlovid will be with us for a long time and really enable us to arrest that reproductive process in the virus, no matter how it evolves. Is it possible we could get a variant, a mutation in the virus that could evade? I think it is, but I think it's pretty unlikely. I think the mechanism of action is what makes Paxlovid such a good option. And molnupiravir as well, that also does that same interruption, just doesn't reduce hospitalizations by quite as much.
Thank you.
All right, thank you, Ryan. Next, we're going to go to Jamie Prito. Jamie, you should be allowed to unmute yourself and ask your question. I don't know your media outlet, so if you could identify that, that would be helpful.
Hi, Jody, Dr. Grace, thank you. It's Jamie Prieto with NBC Telemundo. Now, I apologize. I apologize if I might have missed this, but Dr. Grace, you mentioned it's a completely different pandemic and the virus keeps mutating and so do our vaccines, they keep improving. So can we assume our current vaccines immunity, are they working against BA.4 and BA.5 variants? We know some time has to pass in order to understand how the mutation works better, but is it too early to talk about a possible booster in the coming future that'll give more immunity against them?
Yeah, it's a really good question. And I think you said the vaccines are getting better and better, and I wouldn't actually say that. I would say additional doses of the same vaccine we've had for a year and a half are providing additional protection against hospitalization and death. But I think if I spoke for Mike Edwards and Laura Parahone and other leaders at DOH and myself for sure, if there's one thing we're frustrated with or maybe anxious about, or I'd say impatient is probably the best word, is we would really like to see a more rapid cycle time of development of new vaccines. I think sometime in the first couple months of when the vaccine is available, we started talking about the fact that this is great, we've got this vaccine, and everyone was asking, what's the next vaccine going to be and all that. And, you know, I still hope we get to that annual, you know, coronavirus vaccine like we have had for influenza for decades, that is updated every year and more specific. So I'd like to go in to my primary care doctor in September when I see her and get my new annual COVID vaccine that covers Omicron and, you know, a little Delta and a little bit of whatever's next. I think all the mathematicians of the world are very scared that the next variant is going to be pi, and that'll ruin mathematics forever. But because pi comes after Omicron in the Greek alphabet. But you know, I think what I would like to see is a more rapid cycle time for new vaccines that are specifically targeted to the newest variants. And in some press conference, probably a long time ago, I did point out though, that if you're a vaccine manufacturer and you want to go after Omicron full force, and you, let's just say you started in January of this year, it's going to take you 9 months. Remember, it took 9 months from the first, you know, US broad infections to getting that vaccine in arms in December 2020. And I don't know if Omicron will actually be a variant we'll be talking about in September at the rate things are going. And so that's a tough business decision to invest a lot of money in something that you won't have for 9 months when things keep changing so rapidly. So I have a theory that there's an economic problem there, but I would welcome the day when I can get an annual shot that gets me through the winter, which is the day when Omicron's only occurring in the winter, not the summer, or even two if I had to take it. It was tailored to the most recent viruses. And that's why we see breakthrough cases, frankly, as the virus couldn't infect people who were vaccinated, so it had to mutate in order to do that. And so we're seeing more of that now. So, and I think, Jamie, you're the same person I talked to a couple of days ago. So, right? Is that right?
Yes.
Yeah. So hello again. But that's my take on it. And but I don't think that's going to happen this fall for sure. But I'm hoping with more rapid, I think the solution to this actually is more rapid cycle time to develop the vaccine. And some of the older methods with eggs and all those things we used to use, they can be developed more quickly, and which is what we do with influenza. So we'll see.
Thank you, Dr. Grace.
You're welcome.
Thank you, Jamie. We have 2 reporters left who have not had the opportunity to ask a question. The first is Algernon Demacia from the Las Cruces Sun News. Algernon, you should be able to ask your question, and our other reporter just lowered his hand. So we'll end with Algernon's question.
Thank you. Thank you very much. Just to return to something we've talked about before, and it was a little early, is so-called long COVID, the long-term complications, and how difficult that is to define and study. And I'm wondering if we've been able to improve our ability to get our hands around that for study purposes, and if we have any assessment of the impact on New Mexicans.
Yeah, you know, when I talk to clinical colleagues, I'm getting a more consistent definition of what they're using for long COVID, which is persistent symptoms for 3 months with an additional month of symptoms. I don't know why they don't say 4 months, but that's like infectious disease experts and other people I talk to. I think we've nailed down the seriousness of this, that, up to 20% of people have some form of persistent symptoms, and as many as half of them, they're disabling, like life-changing, life-limiting symptoms. I think there's a number of theories out there about what's causing COVID. You actually still have the virus in you and it's at work, and that's why you're having symptoms and the body hasn't killed it off, or you had the virus in you and now you have immunity and it's that immune reaction that's causing the problem, like other diseases like Lyme disease, which is, you get the infection, but it's the immune reaction that actually gives you the chronic symptoms. Hepatitis C could be either of those. And so I think we're getting closer, but these studies take a long time to design. And I'm hoping that I've talked with folks at the university about how could we expand places for people to be evaluated for long COVID. I know there's some preliminary studies where people have looked at vaccines. Do those help long COVID? Obviously, people are thinking about the treatments. Like, for example, could Paxlovid help? Well, it depends on what's causing it. If you still have virus in your system, like in your intestinal tract, according to some articles, then I think that giving people a trial of Paxlovid, probably longer than 5 days, but a longer trial, that might have real benefit. And I think those are starting to kick off. But if what you're asking is, do we have any better hard data? I have not seen the sort of stuff that I would make definitive recommendations to the patients I have who indeed have long COVID. But I hope we get there. And, I think if you just think about the economic consequences alone to, let's just say 10% of people who had COVID, severely or partially limited in their ability to go to work, do their jobs, and feel good enough to live their lives, that's a really, really big deal. And so I'm hoping we see some more definitive research in the fall. Another thing I will say just real quickly is I think the medical community learned something about how much premature publication of research was done during the first couple of years of the pandemic. And my sense is we're not going to see a lot of rush to market. Here's the miracle cure for long COVID papers like we saw for COVID itself. And I think that's a good thing. I think it means a longer wait. But when we do get the evidence, it'll be better evidence. And that will help me as a treating physician, particularly, rather than just, whatever's on the newswire today.
Thank you, Algernon. I'd like to thank our media partners for attending today's press conference. Dr. Scrace, I'll hand it over to you for any final last words, and then we'll conclude this press conference.
Yeah, I think that I've talked to a number of you recently, and Jamie and I were talking recently as well about just the fact that you guys have done such a great job. You reporters have done such a great job getting the word out. It would have been completely impossible for DOH and the governor's office to keep people as deeply informed had it not been for you pointing people to websites and making it news that something new was available, and and publishing data. So we really appreciate that. I think we'll still need that going forward. And so thanks. And I always like these press conferences, because now you gave me like 6 other questions to keep me awake at night, and I'll go home and our team will wrestle with them to figure out how should we think about that? So thanks for that. And then I would say too, though, that I think there's an opportunity for you all to do what we have to do, or what we all have to do, is just kind of balance the fact that COVID is out there, it's evolving, it's infecting people. We still need to be careful with the fact that it is really a different pandemic than it was 2 years ago. We have a whole slew of really, really effective tools. I'm a geriatrician. I treat people for a lot of different illnesses and diseases. And, most of the things I prescribe are not 89% effective. And so we've got some great tools for COVID. And thank you for keeping that word out there, publishing that, letting people know. And look forward to talking with you again next month. Thanks. Take care and have a good day. Be safe.